Okay, good afternoon, everybody, or good morning, wherever you are in this world. My name is Robert Schroevers, and I'm a psychiatrist and a researcher from Groningen in the north of the Netherlands. Some people might know it because they cross the border for substances that might be illicit in neighboring countries. The topic of this session is psycholytic and psychedelic therapy. And we have two distinguished speakers, Peter Gasser and Torsten Passi. I will first introduce Peter, and then I will introduce Torsten just before his talk. You know how the app works, so if you have questions, please put them in the Q&A, and the moderator and me will then try to enter this into the discussion later on. But first, Peter's talk. Peter Gasser is a physician for psychiatry and psychotherapy. He works in private practice in Switzerland, and he was trained both as a psychodynamic psychotherapist and as a therapist working with mind-altering drugs. He is a pioneer in Switzerland, and I also think worldwide. He's president of the Swiss Medical Society for Psycholytic Therapy since 1996. He conducted a randomized controlled trial with LSD-assisted treatments in patients with life-threatening diseases, and an ongoing study on the same topic that is still running. And he is very experienced both as a therapist and as a teacher. Peter, the floor is fully yours.
Thank you very much, Robert. I hope you can hear me. Is it okay? Do you hear me?
Definitely.
Okay. Thanks for the introduction. Good afternoon, everybody. I try to present you in a hurry. Time is short. The development of psycholytic and psychedelic therapy in Switzerland. I will not distinguish that much between psycholytic and psychedelic because I think Torsten Passi will that do after my presentation. I show you here on that slide what therapy with mind-altering substances has been done in Switzerland since 1947. We have a kind of long tradition in Switzerland with research on mind-altering substances, also in clinical research projects. The first clinical trial with LSD was published in 1947 in Zurich by Stoll. And then we had also, when the ban on the substances was, we had small possibilities in Switzerland to work with these substances. And what I want to point out here now is not the research of the last years, it's more what we can do in Switzerland since 2014. That's where the blue arrow points at. We have the possibility to get individual permission given by the Swiss government for individual treatment. So it's not a research project, it's a treatment project. And we can show what is the naturalistic conditions when we are free in dosage and free to some extent in setting, what is in our view the best kind of doing therapy with these substances. I have prepared on that basis 6 slides that will show you the treatment principles which I think are important to show. The first 3 slides show in sum that this is the treatment which is not only a pharmaceutical treatment, it's not only a psychotherapy, it's not only a spiritual treatment, it's all of the 3. Of course, it is, we give a substance, we give a medication or a drug, so it is a pharmaceutical treatment we are doing. And all research that is done at the moment is on this pharmaceutical paradigm. So we treat LSD, for instance, as a common drug. We do controlled randomized trials to show the efficacy and the safety of the treatment. Although we know that the treatment is more like that, and although we know that a double-blind condition is a difficult research setting because the unblinding of this is nearly 100%. That means all patients, all therapists know if they get the LSD or the placebo condition. However, nevertheless, we have to do it because the controlled randomized trial is the golden standard if you want to make a substance into a prescribable medicine. On the other hand, it is also a psychotherapy, and for me as a psychotherapist, it's very essential to point at that it's not only a drug treatment, it has to be, in our view, embedded into a psychotherapy. That means a therapeutical relationship, a possibility of preparation, and of course of integration of these experiences. Also, the effect of LSD is non-specific in the sense that you don't know specifically that a patient with anxiety problems will have an experience that is directly targeting the anxiety symptom, that will reduce the anxiety symptom by giving once a dose. It is non-predictable in the sense it's an open experience, and the openness of the experience makes it necessary that it is guided by a person who has experience, who know how to go with this process. Of course, it allows people to have regressive biographic states, and in these states, we do therapy. This is highly welcome for doing psychotherapy, so that Stanislav Grof called the LSD a microscope or a telescope of the psyche, or more generally speaking, we can say it is a catalyst or an enhancer of psychological processes. But then the third, we often see, or we see in, I don't know, in maybe more than 50% of the experiences, that people have so-called spiritual experiences, spontaneously appearing experiences of sacredness, unity, mysticity. And although we are not spiritual teachers or the meditative practitioners, we should know about these experiences and help the patients understand what happens here. So it is a kind of existential view or holistic experiences that appear spontaneously. Then more concretely spoken, what are the elements of our treatment? I'm sure that you may know this triad of three elements, which was developed by Leary and others in the 1960s, when they learned that it's not the substance only that makes the experience. It's also the setting, that means the surrounding this experience takes place in is very important. The music, the atmosphere, the room you are, also the therapist. The therapist is part of the surrounding. The attitudes of the therapist, his belief system has an impact. And then the third factor in this triad is the set. The set is called the inner world of the patient. His diagnosis, but not only, also his intention, his attitudes, his fears, what brings him, and what is he expecting from this experience, summarized by set. And these three work together to make the experience. And so we should be aware of the importance, what is beside the substance. And we should maybe more know about how important is music, how important is silence, how important is body touch, and so on. Let me say two things about the setting. What we are practicing in Switzerland is, on one hand, the individual setting. This is a photo of my treatment room where I work with my everyday practice. So I put the chairs aside and put a mattress on the floor and make it a little bit darker, and light candles. And in the corner there, you see also the hi-fi equipment. So I play music. It should be, in my experience, a safe and pleasant environment. The patient should feel in safety with the patient, with the therapist, with me, but also the room where it happens in. This place is quiet normally and undisturbed. Nobody comes in. And I am permanently present and in contact with the patient. So I never go out except for the bathroom or so, but basically I'm there all the time, so that the patient really knows he is in a safe place. On the other hand, with these individual permissions in Switzerland, we do also group therapy. Here you see the group room where I have, together with a colleague, a group of 8 to 12 patients. And we learned that the group setting in itself is also a very helpful setting, because towards the end of the experience, often patients get in contact with others, and maybe they have small talks or they listen together to the music. And especially also the next day when we do a sharing round and patients are explaining and talking about and telling what they learned the day before, what they experienced the day before. So the others of the group, they share that experience, and this is a helpful way of mutual learning. And until now, we have also seen and shown that this can be a safe treatment. So we had no severe incidents in this group setting in Switzerland until now. The next treatment principle I want to talk about is you can not only see the guided experience in itself. When we do this group experience, as I have shown on the picture before here, we have also a preparation on the evening before. So people share what they are in the moment in their lives. They share, and we discuss the next day. We go through what is important. And then on the second day is the guided experience. And on the third day, we have what we call integration. That means people are just telling what they experienced, and we help to understand and to make the experience more applicable for everyday life, so that it can be a long-lasting experience that was not only just a lighthouse experience of one day. It should be a long-lasting way of changing, of transformation, and for that integration is the helpful process. And now also to say, most of the research projects have only one or two of these guided experiences, but we can, when we are free in dosage and frequency of doing these experiences, we do more than two or three. We do likely 5, 6, 7, and it has shown that the therapy, the patients have the best profit when they can do a series of these experiences to integrate step by step what they are coming to therapy for. I have done a follow-up in Switzerland. In Switzerland, we had a 5 years time from 1988 to 93, where 5 therapists were allowed to treat a total number of 171 patients with MDMA and or LSD. And they did not research on that project. So 1 year after 93 and 94, I sent to all of them questionnaires, and 121 of them responded, so that we could evaluate this 5 years treatment phase. We have seen that the duration of the treatment was about 3 years in average. In these 3 years, the patients had 70 normal psychotherapy sessions, and in these 3 years, they did also about 7 drug sessions, be it with MDMA or LSD. I can stop here, but I have 2 or 3 more slides. Shall I stop, Robert, or shall I show the other slides?
Yeah, please go on, Peter.
Okay. Let me say a few things about the future. Of course, I'm thinking what will happen in future, and I think in the global view, we will have a takeover by universities and also by the pharmaceutical industry, who now have a growing interest in these substances and want to make it applicable to a number of people who would need that kind of therapy. The universities will give the trainings and do research projects, I think. And the medication, the industry will try to make these substances as registered medications. And in the end, we hope also that health insurances will cover these treatments, because the treatment is expensive when it is outside of research projects. it will be important to train a sufficient number of therapists. That will be crucial because all these therapists have to do all the research projects that will be done the next years. There are also two questions, at least two questions for me. What happens to the people who want to take these substances outside of the medical framework for personal growth, for self-experience, for meditation or whatever? Will they have access to these substances, although they are not patients? And the other important question is, of course, will there be backlashes, severe incidents that will maybe give a breakdown of all that, what happens now, like in the late 60s and early 70s when the research and the treatment with the substances came to a halt because of the hippie movement. You know that story, I'm sure. In Switzerland, we do more or less the same. We try to develop our compassionate use program, individual treatment approval, because this is a unique possibility to get information about what conditions can we treat and what is the best setting and all that questions we can have, preliminary experiences with all that. So we also will have to do further studies in Switzerland, phase 2 and 3. There are, especially at the universities of Basel and Zurich, are research groups who are capable to do further studies. We, and when I say we, I speak for the Swiss Society for Psycholytic Therapy. We think about therapist training. We will have 2 panels this evening where we discuss this question about therapist training, which I consider to be a very important question. We are discussing also about ethics, because the ethics of this kind of treatment is very important. It is special. It is the same as psychotherapy in general, but it is also special. There are other questions to discuss who are only for this kind of treatment of importance. And then what goes on is public information. And the last 10 years, I think we tried to give the positive information because there was so much prejudice about this treatment. Now I think more and more we also have to warn and to show the dangers of the treatment. This is not helping everyone and it is not applicable in any cases. And we are the experts. We can also, I think, more and more target and say there are dangers and we must keep that in mind as well. And the final thing I want to show are the take-home messages. It's a summarizing what I have talking about, now I've been talking about. I was talking a lot about LSD because I'm most familiar with that substance, but this is applicable for MDMA, psilocybin, DMT, and maybe also for mescaline as well. It is important to say that these are not drugs in the common pharmaceutical sense. They can be understood as enhancers of psychological processes. However, they are treated as normal and ordinary drugs in the regulation process. And LSD and other drugs have to be incorporated into a psychological treatment because of these specificities that I just mentioned. And also, I mean, it's obvious the current research and the evaluation of LSD gives promising signals towards a reuse in several medical indications. Thank you for attention.
Thank you very much, Peter. As Thorsten will probably use all of his time for the talk, Peter, I think there's a few minutes for some questions. Some people were asking about the group sessions. With how many therapists do you do the group session?
Yes, we do the group session with 3. So we are 2 male and 1 female. I think it's important when you do groups to have a male and a female therapist, because I think there are situations it's better for the patient to address to a woman or to a man. And I think when you are more than 1, then you should be of both sexes.
Okay. Is the group session the first time that the group meets? Because you've told earlier that the psychedelic session is separate, and then in the group you discuss their experiences, if I understand you well. But is that also the first time they meet? Or
no, the group starts on Wednesday evening for the preparation. So all of the groups, they gathered the first evening, and then we have an evening session. They go home. The next day they come all together for the group. And then on the third day, the morning, we have this integration and discussion. And this is all, the whole group is together. And as patients have more than one session, they will meet the same people next time and the time after. So then by the time it gets to be a constant group also, people know each other.
Okay, thank you. And you were referring briefly to the possible negative consequences. There was one question on what do you think the primary dangers are and how should they best be handled?
The primary danger.
Sounds a bit threatening, but.
Yeah, one of the dangers could be that we overestimate the method, that we think we can treat and heal everyone. I think this is a danger. And this is all a danger because, I mean, there is a lot of glory about these substances, and because the polarization is so strong, one sees it as a big danger. There are evil drugs, and others say, no, these are sacraments, and those who give it are the priests or the gurus. And I think this is one of the dangers, the exaggeration of expectation around this method.
Okay, thank you very much. In view of time, I also announced that there is a separate breakout room with Peter and Torsten directly after this session. So if you have further questions and it fits your agenda, then people can ask them. Now it is my pleasure. Thank you very much, Peter. It is a great pleasure to announce Torsten Passi. He studied philosophy, sociology, and medicine, and wrote his dissertation on existential psychiatry. So he has been involved with these kind of subjects for a long time. He led the Laboratory for Consciousness and Neurocognition at Hanover Medical School, and he studies different aspects of psychedelic experiences and therapy. And he also had a visiting professorship at Harvard Medical School to teach and do research on this issue. Torsten, we'd like to hear your talk.
Yeah, I have to look at my thing again. How do I get my slides in? Still a question.
In the middle, under there's the green share screen button. So if you have the slides.
I've done
that.
You
have the slides on your laptop?
Yes, on the desktop.
On the desktop, and then with share screen, it should work.
No, it doesn't.
Yes.
In Zoom, you still have to click on yes. Perfect. All right. So you're sharing your screen.
See
so if you
your...
open up.
Okay.
Yeah, I think
I need a second.
It's coming up. Yes.
If we lose time on that.
Perfect.
Okay, I will give a short outline, and nothing more is possible, about a low-dose psycholytic therapy. And it came up to my mind that what I've learned with Hans Karl Leuner for quite a while is right now a neglected approach. Everybody is looking out for ego dissolution and psychedelic experiences and so on, and nobody is really looking out for the laborious work of psychotherapy in the psycholytic paradigm, which is different from the psychedelic paradigm. Let me give you a very short outline about the history. The shamans were the predecessors, obviously, and Baroni in 1931 did psychoanalytic sessions under the influence of mescaline. He was the first, it has to be mentioned here. Then there were other psychotherapists using daydreams at that time during the 1940s. That was the beginning of that. And then Stoll's first LSD study appeared in 1947. Let me just mention that Stoll used doses in the range of 10 to 30 micrograms. So he was more in the psycholytic range, in the low dose range. And then coming from that, Hans Karl Leuner in Germany, Ronald Sanderson in the UK, and Stan Grof in Czechoslovakia used the psycholytic approach to treat quite a bit of patients. And at that point of time in the mid-1960s, there were 18 European, mainly academic centers treating with that method. While in the US, there were just a very few people treating with this, doing treatments with the psycholytic approach. They were more into the psychedelic approach, as it is today too. If you look at the therapeutic research, you could say that the number of publications was very high during the 60s and became very low up from the 70s. And I want to make you aware that if you look at this statistics, a quarter of them was about psychedelic therapy and 3/4 about the psycholytic approach, where I give you an introduction about. But important to know why we are on the psychedelic paradigm right now as much. There was, the background is that there was an interruption of research in that period, and MAPS, as well as some American and Swiss millionaires, were the only people financing these kind of research in the therapeutic applications. And in the end of the 1990s, they were sitting together and thinking about how can we prove positive effects of psychedelics on mental health in a very easy to conduct way without so much money. That was their idea. And what they came up with is we have to do short-term studies. So we have to use high doses, give it a certain impact so that we can easily measure it in a very short period of time. This way is easier and cheaper to prove that these substances can have positive effects. So the psycholytic approach, which is a much more long-term approach, was completely neglected out of that paradigmatic way of conducting studies out of this historical situation. And interestingly enough, even up to now, there's no imaging on psycholytic doses, means low doses, and there was also no research on psycholytic therapy up to now in the recent revival. What is psycholytic therapy? So psycholysis, as it was also called, or psycholytic therapy, came on in the framework of psychoanalysis at the time. And the term psycholysis was coined by Sanderson in 1960, no better picture available, an UK psychiatrist and psychoanalyst. And these guys were using low doses, mainly in the range of 50 to 100 micrograms, and they gave quite a bit of more sessions. You have to also realize that at that point in time, there were a lot of treatment-resistant patients which have to be treated. And so therefore, they used more sessions because the people were more gravely ill, so to say. And interestingly enough, they used LSD mainly, but they stopped the LSD reaction after 4 to 5 hours with a tranquilizer or a neuroleptic drug, so that it was fitting in the clinical environment better than a 10-hour session. They were treating inpatients, later on quite a bit of outpatients with that method. And at last they came up with the idea to treat the patients just in an inpatient environment, just for the session itself. And so you have them going a few times in the hospital for the session for a 3-day interval, and then afterwards you treat them with conventional therapy, and maybe 4 weeks later you do another stationary interval, so to say. What is the setting? The setting is that it was generally embedded in a long-term therapy, like 1 or 2 years usually. Patients were never left alone during the experience. That was a paradigm found to avoid dangers. A therapist or a nurse sits with the patient. It could be also a nurse or a medical student or somebody as a person accompanying the session. And the session will be tape recorded, and a written protocol will be done. It is important to realize that the nurses or other people which were kind of not guides, but accompanying the session, sitting in the room with the patients, were supervised by a therapist which comes in once in a while in the treatment room. Psychotherapy as well as art therapy was used for integration with these, especially in inpatient settings. You have to realize that even virtually all of the material on which Stanislav Grof's prominent book was based was an outcome of his treatment of 50 patients in a psycholytic way. So realize that if you look at this book. Here you can see a conventional psycholytic setting, a small room, and a person accompanying here, in this case me, on the left side, and in the center is Professor Hans-Karl Leuner sitting with the patient. He came in once in a while, and we're looking out for the patient. Is the patient is relaxed, or did he do some intervention or stuff like that? And here, the outpatients in an office could be treated, inpatients. And an interesting thing was that in the clinic, it was not a group therapy. It was group therapy in advance of the session and afterwards, but the sessions itself were done in individual rooms, but to more than one patient simultaneously. Group therapy if you have the patient in a clinic for a longer time, there was an arrangement which is called therapeutic community, not as much known today, but a good approach, I think, where the people can work together and experience together after they have gone through the sessions. And here you can see an outline of such a treatment department, so to say. You have different treatment rooms where the individual treatments were conducted, and the group room where the people share their experiences afterwards. And here is, in fact, the only specific LSD therapy building which has been built in the UK by Sanderson's group. And you can see in the forefront here these little chambers and the group room with that window there. And what kind of substances have been used? LSD and psilocybin mainly, but later on Sandoz produced some short-acting psilocybin derivatives as this one, and Leuner's last study was with a mescaline derivative, also very short-acting, 2 to 3 hours, called 2CD in Schulgen's terminology. Okay, Okay, what were the treatment results? As you can see, number of studies, there were quite a bit of studies which have looked out for the results of these treatments. They were not as methodologically sound as today, but they brought in some evidence, and you can see anxiety neurosis, depressive neurosis, character neurosis. At that time, the terminology was neurosis. You can see that the treatment success was quite okay, and please realize these were mostly so-called treatment-resistant patients. And I will give you 2 quotes from non-psycholytic therapists, but knowledgeable people. I hope you read it all, and I will give you some ideas about the mechanism of action. So right now we are talking about the psychedelic approach, mainly dissolving the ego, and then you have a better treatment result. With the psychological approach, it's different. So I put it just to give you a rough idea, some features of ego functions here and their usual arrangement, just to make it more clear to you that under a psychedelic drug, these functions might be minimized or maximized or altered in a certain way, and also their constellations are altered, so that another experiential flow will come together. And I will give you also an idea about what Leuner found and used or created a specific term for. So if you have the ego and the ego functions here, you have less ego functions going on during a psycholytic session. But interestingly enough, even if your ego is not there in the usual configuration, you have still something what Leuner called the reflecting ego remnant. So something in your psyche, so to say, or in your mind, which is reflecting on the experience, so it passively perceiving it and but still there in a control fashion, in a way that you still can realize you are under a certain drug, right? And you're not lost somewhere or something like that. And you can also, coming from this reflecting ego remnant, you can also influence the flow of the experience to a certain degree. So ego functions are altered and sometimes reduced, but partially intact, which is not the case with an ego dissolution, right? The configuration of the ego function might change, and a reflecto ego remnant is left. This is a typical psycholytic session. And if you look at the PET scans of Franz Vollenweider during psilocybin, you might see that, especially, I can't go into details here, but in the middle of the brain, you'll see on the right side compared to the left side that it's more activation there. It means the thalamus, the filter, is more open. So you perceive more of your emotions, of your thoughts, and these kind of things. And so this can be regulated in a certain fashion. I will come back later to that. So this is here. So what Leuner found in his clinical research, conducting 1,000 psycholytic sessions in a row, he found 2 courses which the LSD reaction can take. One thing, the first course he called the continuous scenic course, also called the quasi-normal course. This is when you have a smooth, continuous flow of images and insights. So it's no ego dissolution, it's more a dreamlike state where everything is kind of coherently showing up. And there is a holistic, typically a holistic kind of integration of these visions and experiential flow with the appropriate emotions or affectivity. In contrast to that, he found a stagnated, fragmented course, which is characterized by overexcitement and the fragmentation of the experience, as well as a disintegrated ego and an erratic flow of experiences, which is much more not coherent, incoherent, so to say. And to make that more clear, I will give you 2 diagrams here. Here you see the continuous scenic course, and here I put a line in there. So if you go above that, you go more into psychotic ego fragmentation, and kind of that might be even called, in a positive sense, if it is a positive mystical experience, an ego dissolution. But Leuner tried to go below that threshold so that the experiential flow is more continuous and more daydream-like. And here at hour 4, you see that kind of little hook here, which is also a finding of him. I can't go into details here, but this would be the other stagnated fragmentary course. So you go more in above the threshold, and your experience is much more fragmented and much more vulnerable to erratic, incoherent, fragmented experiential parts, so to say. So he tried, in fact, to avoid the stagnated fragmentary course, but sometimes if it comes to highly loaded emotional experiences during the psycholytic flow of the experience, you might also go sometimes temporarily above the threshold into that other realm. And so therefore, it could be said that if you put the conscious and unconscious together that way, as I've done it here, following Freud and Jung, you will see that the consciousness is just a very little bit of the matter, and what can be made conscious is a little bit more. But with psycholytic therapy, we try to extend the conscious sphere as well as this facultatively conscious sphere. So the upcoming of content in these sessions is what we wish for, and that the people realize more of their inner space, their feelings, their thoughts, and also their suppressed emotions and unconscious contents as well as conflicts. And so I'm at my last slide here. So what are the mechanisms of action? I can't go into details here. It has been evaluated in a very detailed fashion, what is really going on, by Stanislav Grof as well as Hans Karl Leuner. The general idea is that affective complexes, so you could say traumas, turn into visions bit by bit. And this is why you need more sessions, but it might be also more mild and more smooth. And there is a memorization and affective abreaction. That is a major feature of psycholytic therapy, so that these things come up and you will experience them and express them in different ways. And there's also a strengthening of the transference that is known from psychedelic therapy too. And a lot of these patients see their defense mechanism in real life. And that makes them really obvious to them, which can be a very good feature in psychotherapeutic work. There are also productive alterations of scenes, means if you go into your fantasies and visions, you will sometimes produce an alternative scenario, so to say, where you behave in an alternative way. That can be also very freeing, so to say. And there are also a lot of spontaneous insights and self-analytic thoughts. So the synopsis is there is, in fact, right now a neglect of psycholytic therapy because everybody wants a short-term magic bullet, 2 times healed thing, but it might be true that in the near future, we will see much more the limitations of that approach and that we need longer time. Peter Gasser has mentioned 7 sessions, 70 hours of therapy, which is 1 or 2 years. So that approach is clinically already going on. And there are different mechanisms of action with the low dose psychotherapeutic use of LSD. There are alterations of ego functions as a main feature. And the question of durability in respect to therapeutic results may come up soon with the psychedelic approach, I think, especially if it's not consequently embedded in a long-term psychotherapy. And the future might be what Peter Gasser and others in Switzerland are already practicing, which is a kind of combination of a little higher dose, allowing for psycholytic experiences as well as for psychedelic mystical kind of experiences. Thanks for your attention. I hope I'm not too much over time.
Thank you very much. No, you're perfect within time and a very clear talk. Thank you very much. I was looking at the questions. We will not be able to address all questions, but could you explain whether there are differences in the role of the therapist in psycholytic versus psychedelic therapies?
Yeah.
And then maybe specifically in the session.
Yeah, okay. So you are right by saying the last part of the sentence. So there is the psycholytic approach is more like helping the conventional psychotherapy. It's much more about that. So the significance of the therapist is much greater. But to come to the core of the question, it is the case that when I worked with Leuner, so I thought at first, oh, let's look how he intervenes. We didn't intervene as much. We were very passive, but we were the people, the patient could speak to us and we will answer, but we will never intervene actively. Just the therapist, if he showed up, he was looking out for the patient, asking him, how do you feel? How is your tension? He grabbed his hand and feel if he's sweating or he's under tension and stuff. And then he tried to calm him down again and asking for what's going on in your mind right now. How do you feel? Oh, it's about your mother. What happened there? And so you can deepen the thing. And I would say quite the empathetic embedding of the experience is less with psycholytic therapy. And also the music is much more in the background. So let me say, the therapist has not to be as much of a DJ, you know, because the music is really marginal, right? But it's there. Usually it's there, but very low volume and a smooth kind of sound. It's not really psychologically activating in any sense.
Thank you. And maybe also for the audience to explain, in psycholytic therapy, would you give lower doses in like 5 or 10 sessions in a row, or would you also do just a few sessions within a longer range of psychotherapy?
Yeah, it is usually in the longer range of therapy. You could say 1 to 2 years, and you conduct, I would say they had these treatment resistant patients, so they use more. I would say it's in the range of 5 to 15, and the usual it's around 10, kind of. But it's really a different deal. It's something like you change in a much more smooth and successive session the patient and their behavior and maybe their neurotic tensions and stuff in a much more gradual way than with psychedelic therapy.
Thank you very much.
So it's not so to say, it's not as much about integration. Okay.
Thank you very much.
The psycholytic experience is the patient is able to integrate it somewhat during the session, because his ego functions are still there somewhat.
Yes, yes. No, you explained that very clearly. And I think the image of many people is now determined by psychedelic, whereas as psychotherapists, we would, I presume, be more inclined to be interested into the psycholytic, because it's more, it fits better within a psychotherapeutic frame as we know it. So it's conceptually, it's very interesting, and also clinically. I give the microphone back to Joost, who is in the red room, and but maybe Joost or one of the moderators could explain how people could ask questions directly to the speakers in the breakout room. Thank you.
Yes, thank you very much, Robert. Thank you for the handover. Thanks again, Torsten and Peter. Yes, I do need to tell you that we've posted the links to the meetup rooms where you can do an after talk with the panelists if they're available in the description in the Whova channel. We'll also post it here in the Zoom chat. After the Zoom closes, you'll lose the chat, so go back to Whova to find the direct link. And this will enable you to continue the conversation with Torsten or Peter. I'm not sure if they've been told beforehand. Sometimes this information gets lost. I will send the link to Torsten and Peter straight after I close this. But there is the opportunity to...
Sorry, we can use the same link, Peter and me?
Yes, please.
Okay.
Yes. Okay. Yeah, you should actually, if you don't click the link first, it might be full. There's a capacity of 30 people. So please wait. Please don't click the link until Torsten has clicked the link. And maybe he needs some help as well. But thank you very much, guys. We do have a short break in which people can attend a mild breathwork session. I think that may have already started. So I'm actually not sure if you're able to join that session. After the break, it will be, for me at least, it will be super difficult to choose, because we have one track that touches on this issue actually. There will be different models, integral models of psychedelic therapy, which will be moderated by Janice Phelps. In the Dobkin de Rios room, we'll have an interview with a renowned ethnobotanist and anthropologist Wade Davis. And then in the third room, we have a couple of people addressing ethics, transparency, and open science in psychedelic research in particular, which I think is also a very important topic. So this will be hard to choose, but on the positive side is everything will be recorded. So if you miss something, you can easily watch it back afterwards. Also, please don't forget to look at the posters when you have time. You can do this after all the sessions are over as well. But don't forget to look at the posters. People spend a lot of time preparing both posters and actually presentations, walking you through their posters. And don't forget to have a look in the poster session booths for the indigenous projects where you can donate. I think that wraps it up for this session. Thanks again, Robert. Great to see you. Same for you, Torsten. Same for you, Peter. And go ahead and click the links to continue talking to them.
Thanks to you, Joost.
Thank you, Joost. Bye-bye. Bye-bye, Torsten and Peter.
Bye-bye.
Thanks a lot.
Bye.